everyone for joining. You are at the International IVF Initiative in spite of my background. This is RBM Online live. First session with RBM Online. Thank you and welcome. For videos of previous sessions, as you know, those you can find at ivfmeeting.com. You will also find information about upcoming sessions on that same page. Thanks for logging in, and I encourage you to ask your questions. Feel free to ask questions, but only using the Q&A section on your window, on your Zoom window on the right bottom side, okay? Not in the chat function because we may miss it. I'm here today with Chief Editor of RBM Online, Professor Bart Fauser, who will moderate this session with me. I've known Bart for many years. It's been decades, really, letting you in a secret here. You should really check out his amazing bio on our website. We don't have time to go over every aspect of his bio. He has been involved in almost everything in assisted reproduction and reproductive development today, with more than 500 papers, has held many prestigious positions at academic institutions in the Netherlands, and holds numerous leading professional society positions. I really welcome Bart, great to see you. And I'm very happy to do this together with you.
Thank you, Jacques. Yes, to all of you, morning, afternoon, evening, welcome to this, I think, special occasion, joint RBMO Live I3 initiative session. We all are really keen to see how it's going to work. We love to have your feedback, both by questions and also later on about the session. So my name is Bart Fauser. I'm from the Netherlands, Chief Editor at present of RBMO Online. And indeed, it is a great pleasure to do this together with Jacques. Indeed, not many of you may know, but we are both Dutch origin. We know each other indeed way back from our PhD time. And I think we had our first international conference and lectures together. And also what we have in common is that we both are closely linked to RBMO. Jacques, as a previous editor, I succeeded Jacques about 5-6 years ago. And it's a great pleasure to do this. So RBM Online, I'm not sure for all of you, but as a very, very brief introduction, it is a journal that was established by Professor Bob Edwards in 2000. Actually, he started this journal after having been very active in ASHRAE and founding several journals in that particular society. And for this, his aim has been from the very beginning had to have science shared between the ones performing, the scientists, the clinicians, focusing on research in the broad scope of reproduction, biology, translational science, clinical science, focus on human embryo, and way beyond, including experimental studies in animals. So bring this together. At that time, of course, the word online had quite a different meaning, or was more innovative than it's now. And therefore, it is, I think, a wonderful step to go from online to live. And therefore, this is a big day for us. So we hope we will add to your knowledge. We will add for the visibility of the journal, because it's not something new in terms of the work presented, has been published before in our journal. But it's bringing this information to you in a different format. And we are really proud to be able to do this together with the International IVF Initiative, I3, who have already in their short history shown to all of us how effective they are in sharing knowledge, which they do on a regular basis. Usually it's more around a theme, so more focused. For this, we intentionally said we'd like to have it broad, because we have a broad scope of the journal represented in today's presentations. And altogether, we are going to discuss 5 papers, 4, one as a standalone lecture, which we will start with, and then we will have 4 speed sessions. Brief presentations, one by one, maybe with 1 or 2 questions from both the chairs, but then there will be lots of time for questions thereafter and interactions with all of you. And we hope we can all motivate you to deal with this. Then move to the first lecture, which was actually, we have the tradition in the journal to have a Bob Edwards prize-winning paper. It goes through very serious reviews in different layers within the RBMO family. And this was the 2013 prize-winning paper on genomic DNA in human blastocoele fluid. And we would like to start with this. So with Simone, who will start. He's a senior clinical embryologist. He's worked in quite a few different public and private laboratories in Italy, in Europe, as well as in the United Kingdom. And you can find more detailed information about his bio in the I3 website, which is ivfmeeting.com. So Simone Palini, please, we look forward to listen to your presentation.
Okay, I win the prize in 2013 and was really exciting discovery, find DNA over there. And from that moment, a lot of things happened during my scientific life on this topic. And we start with the DNA, and then we arrive to study microRNA coming through oncological test, as well as in IVF, try to put this new strategy of non-invasive genetic diagnosis inside the daily use of IVF laboratory. So in 2013 was a great publication, because at that time nobody was struggling with DNA in other matrix like culture media and the blastocoele fluid. And from that everything is starting, and I'm here to describe what happened during this life after this big research. Thank you, guys, and I start my presentation that the title is "It's So If You Think So," and then we will understand why. This is the story of genomic DNA in human blastocoele fluid. It's a kind of revolution of the paradigm, and we find DNA in other matrix. The next one. And the next, it's the article on the left side, published in 2013, and that we won the Bob Edwards Prize, and we are really proud. And on the right side, we can find the first time that we saw in a PCR, in real-time PCR, the curve that is growing up after 25, 28 cycle. And Professor Luca Galluzzi, that is a seat on the chair, told me that maybe it's rubbish. Okay, we go ahead. But was not rubbish. This video you can see on internet is the collapse of blastocoele fluid. Go ahead. And was not rubbish, I said, but was a new matrix with the DNA suitable for the amplification and the genetics testing from blastocoele fluid. And this was a great opportunity for us. And thanks to this research, we open a new era of minimal invasive preimplantation genetic diagnosis. We can go ahead. So at the end of the day, the loss of blastocoele fluid is not so detrimental for the embryos. In fact, we know that usually the blastocysts are like a squishy. I mean, physiologically, they collapse and then re-expand, collapse and re-expand. And also during vitrification procedure, we we try to collapse the blastocyst, remove the blastocell fluid, because it's a kind of barrier of the incoming cryoprotectants, and it's the possibility to develop the ice crystal inside the blastocell fluid. Go ahead. So we can go ahead. The problem was that the DNA over there, it's really few DNA, about 10 picograms we estimate, because we are still not able to purify and quantify this DNA, because it's DNA of poor quality. It's fermented, and we really doesn't know if represent the embryos in his development, and also we don't have right now the instrument to study this new matrix. Okay, go ahead. So a lot of articles try to find the DNA inside the blastocell fluid. Everybody are trying to do with his buffer, his VGA, his genes, and each one more or less find what they are looking for. It's so if you think so. So for the PGM, PGTM, it's possible to find every kind of gene that you are looking for. Go ahead. And as well as in this slide is represented all the articles that from blastocell fluid try to perform PGTA with different amount of matrix, because they aspirate the blastocell fluid in day 6, day 7, day 5, so the amount is different. They're using different buffer, they're using different technique, they're using also different bioinformatic solution to arrive more or less at the same result. But they are trying still to compare what is the DNA, the euploidity of the blastocell fluid compared to few cells in the trophectoderma that we know that the cell of trophectoderma are mosaic cells. So go ahead. There's a lot of problematic inside the blastocell fluid contamination, that contamination and result. So the results are really variable one with the other, because we don't have a learning, we have not considered the learning curve, we have not a protocol to how aspirate the blastocell fluid. We don't know the amount of the DNA, we don't know nothing about that, and everybody arrives to different results. Go ahead. But the main problem, in my opinion, is not to compare the quality of DNA to the blastocell fluid to the trophectoderma or inner cell mass or few cell of trophectoderma inner cell. The problem is where this DNA is coming from. Is cell-free DNA? It's coming from apoptotic of necrotic cells. It's an informative. It's really important, an informative vector for other cell, for the self-organization. Maybe it's arrived from apoptotic and necrotic cell. Why we say so? Because we have seen the Smirna, I mean the formation of oligomers around the 108 base pair that is characteristic of apoptotic and necrotic cell. Go ahead. So maybe this is one solution. The other one, it's explained by Bolt in 2016, that he showed us that in trophectoderma, the trophectoderma of murine embryos, the abnormal cell has a different kind of cleavage. I mean, and then go slowly to expire, to finish. While the inner cell mass cells usually are removed by apoptosis. And people start to speculate to this concept, also and we said, if we lost the aneuploid cell in the culture in the blastocell fluid. So we have a lot of aneuploidy in blastocell fluid. We will have, of course, euploidity inside inside the inner cell mass, because we know that there's a kind of euploidization procedure mechanism that is horn of the embryos. In fact, Dr. Greco and Maria Giulia Minasi published in 2015 a wonderful article that showed that it's possible to achieve the pregnancy also transferring embryos with deep mosaic. We can go ahead. And they try to compare the blastocell fluid, the DNA of the blastocell fluid amplified with the technique used for the cytogenetic matrix and the cytogenetic technique. So they move this technique to the blastocell fluid. They arrive to conclusion really different and conflicting one with the other. So we can go ahead. And because maybe inside we can bring with the pipette the DNA from the cell when we inject the pipette inside the cell for the aspiration. Go ahead. But the contamination could be also from the culture media, from the mother, from the embryologist, and blah, blah, many other contamination. Go ahead. But now we know that also in the culture media, we find DNA also in the blastos, we find DNA in the blastocell fluid, but we also find the DNA in the culture media in 2015 with the article of Professor Luzzi. But this article that is published a few years ago, the last years, I think that it's a kind of milestone of non-invasive preimplantation genetic diagnosis. It's a multi-center study with 1,300 blastocysts analyzed, and they arrived to great conclusion that the concordance between the blastocell fluid and all the embryo is about 78.2%, so it's quite high, and 87.5% of that DNA comes from trophectoderma, the other one from the inner cell mass. So, as we told many years ago, the culture media and the blastocell fluid, it's the composition of how the embryo is going on. It's not only the photo snap of a biopsy of few cells in that moment, but you know, sometimes police when do the endogeny for some people is looking inside the rubbish to understand the life of these people. So we are doing the same, looking inside the blastocell fluid and the culture media. We can understand better the life of these embryos. Go ahead. So, and we can go ahead. So they are pushing that in the next few years we will close to use this technique, free culture media in free blastocell, free DNA in free cell DNA in the culture media. We will use like in the pipeline of IVF lab. We also find inside the blastocell fluid, as well as in the culture media, DNA enclosed, DNA and RNA families enclosed in the membrane. I'm speaking about microvesicle, apoptotic body, and all the other vesicles that are really informative right now. We are moving all our concentration on this new vector, informatic vector that is microRNA's family. And with Professoressa Di Pietro and Rosalia Battaglia, we won the GFI, and we are, okay, go ahead, studying the blastocell, the amount and the identification of which kind of microRNA are inside the blastocell fluid. Go ahead. We found a lot of microRNA starting from 900 microRNA, and then we decided to study only 96 microRNA in this new panel with the TLDA method. Go ahead. And we find that 15 of these microRNA are involved in the maintaining the viability of the inner cell mass, as well as are involved in the mechanism of implantation. Go ahead. Why? So, okay, so why we are studying microRNA? Because microRNA are involved in the infertility procedure in many steps, and comes from many different cells, like sperm, oocyte, cumulo and corona cell, as well as from the embryos. Okay, go ahead. So, but maybe, as I told, we have to change our mind. Maybe we can study with our instrument a new matrix like the blastocoele fluid. We can study in the rubbish of the people. We can't use the same instrument that we study, that the psychology using to study people, studying the same people from rubbish. So we have to change the concept of our endogeny, our knowledge. So go ahead. Because in our study, in the study that I show you, you can see there's a lot of disorder, a lot of chaos, and different result. But at the end of the day, each one is coming to the end. Everybody find the DNA over there. Go ahead. But with not good instrument. So we are struggling with chaotic and non-linear results that laboriously are represented with a classical mathematical equation. The result could be perhaps better represented by a different approach, both for biotechnology used as well as for the classical vision of DNA that already is fallen, because DNA is not more only in the nucleus, but we can find DNA everywhere. So maybe matrix and the Hamiltonian calculation, I mean, the calculation using in the quantum physics, could be the best mathematical tools to represent this new reality that we are understanding and adding, try to interpretate. We can go ahead. I mean, we are struggling with microRNA that are 18, the smaller 16 base. We are really close to the quantum, more close to the quantum field instead to the material one physics. And we know that in that dimension, the matter could be waves as well as matter. So maybe we have to move our conception in our mind and start to think like a bigger waves that under the incipit of material, the waves collapse on the materials and became matter as well, like Schrödinger said. When we will be able to understand this concept, go ahead, we can understand really better this slide that I would like to summarize, but with new conception that the primer is the incipit of materia and the DNA is the big waves that is able to collapse, to be amplified. Go ahead, please. It's not the idea. If you think so, is a wonderful commedia of Pirandello, amazing book that speaks that the reality is what you think. And it's the same that Schrödinger and Dirac and all the physics that are speaking about quantum physics are saying. But in our mind, we have only to understand that to shift the materials, to shift the vision of material depend from us, because we will be able to open the second hole, like in this slide, and give the possibility to the matter to become waves and start to think in a different way. Go ahead. So Why I say all this quantum concept? Because when I study biochemistry, yes, there's the same thing that Pietro is my big son is studying, but with more detail, and some theory are changing. So maybe Paolo, the second son of mine, maybe we will study different things that Anita study different other things from Paolo. Okay, go ahead. I would like thank you everybody, but Sylvia, my wife, that she's an embryologist as well, and she delivered a few days ago, Anita, my last daughter, and I would like to thank you with this sentence that infinity is behind the hedge. Thank you.
Well, thank you very much, and congratulations with that good news there at the end. And it's good to have you live. There were some internet connections yesterday, and so Simone's lecture was taped and very clear, I think. Thank you very much for that presentation, and thank you for and thank you for that paper in 2013 and that work, which really has been a revolution and is still under debate, of course, because these things don't go very fast. And as you know, as you point out, I think very correctly, it's very complicated. But I think it's a great addition to PGTA. So we have some questions here from the panelists as well as the audience. You present the likelihood that the DNA is not necessary from healthy cells. Why do PGTA laboratories insist to translate the non-invasive PGTA test results into a cytogenetics report? So that's the first part of the question. Why does it have to be a cytogenetics report? Why could it not be a ranking report? So not providing any aneuploidy or euploidy or mosaicism information. So you would say, well, this is the first embryo that I would transfer. This is the second, this is the third, if there are that many embryos. And
yeah,
I wouldn't transfer at all. Yeah.
Yeah, we can start with the first one. I think that looking for euploidity inside the embryos is like to go in the trees of pear looking for apple. This is my point of view, because we have to change something in our mind. It's not possible to looking for euploidity in a system that is still open, that is still something that must making up the differentiation. The DNA is a big vibration. Sorry if I speak in terms of frequency, vibration, and energy, but we are speaking of the born of the life. Something that is so strong that nobody knows. We are playing with this game, but it's not a game. We are arrived at the end of the day that we are struggling with this energy, and we have to move from the to a quantum physics. So when you accept because you accept my article in 2013, I sent to you few emails before, try to push to you to trust me, because nobody believed to find the DNA over there. And nobody believed me now that we have to move our mind in the quantum physics. I know, in quantum physics, I know it's difficult because we have to start to study something of new. And then when we maybe understand something, we have to translate this in IVF field. So this is what we have to do right now. This is the upgrade. Not to looking for DNA, a concordance between the few cells in the trophectoderma and the rubbish of 3 days. How is possible? You have to use some instrument and start some alchemic strategy, because is not possible to think. So this is my point of view. Moreover, if you wanna that I answer to your question, I can answer to your question, but we are really far. I would like to give this seed to the mind of all these people that are listening this webinar and try to see in the next 10 years maybe new flowers that are coming from.
Okay, great. Well, thank you. And it puts it in a philosophical perspective that is intriguing, and I think you give us all food for thought. Thank you very much again. The next few speakers are in what we call a speed round. These are all publications from RBM Online that were published in the last few months, last 3, 4, 5 months. And so we've picked 4 papers. These are from the fall to present briefly and in a review format. All articles can be found online on the RBM Online, RBMOjournal.com website. And we have 4 distinguished speakers and their bios can be found on the I3 website. So we have Professor Joyce Harper, Professor Antonia Lamarca, Dr. Mehmet Resit Asoglu from Istanbul in Turkey, and we have Dr. Maike Schnoor speaking on behalf of Dr. Suzanne Elsner, who sadly could not be with us due to illness. So Professor Joyce Harper is an author, academic, scientist, and educator. She's Professor of Reproductive Science at University College London in the Institute for Women's Health, where she is head of the Reproductive Science and Society Group and Director of Education. She has worked in the fields of fertility, genetics, and reproductive science since 1987. Published over 200 papers. She started her career as an embryologist and then moved into reproductive science and genetics. Don't know if it's a step up or a sideways. Now she is researching fertility education, the social aspects of fertility and infertility, from social egg freezing to childlessness and femtech. I'm still going to introduce the other ones, Joyce, before you start. Professor Antonia Lamarca is a professor of obstetrics and gynecology at the Department of Medical and Surgical Sciences of the Mother, Children and Adults of the University of Modena and Reggio Emilia in Italy, and is the clinical coordinator of Clinica Eugen in Modena. He's both an MD and PhD, the latter with a thesis in biology of germ cells. In addition to his very diverse clinical and research activities, Professor Lamarca is a much requested lecturer. He does this weekly. He's an active member of several national and international professional and scientific societies and consultant for the Italian Ministry of Health for infertility-related issues. He's a busy man. He has published extensively, more than 180 papers and numerous textbooks. He is a member of the editorial board of RBM Online, also a member of the editorial board of Frontiers of Endocrinology, and is an editor-in-chief of Minerva Obstetrics and Gynecology. From Turkey, we have Dr. Mehmet Resit Asoglu, who is an associate professor and MD since 2006. He has been working in one of the largest IVF centers in Istanbul, in Turkey. Dr. Mehmet manages couples seeking help for assisted reproductive treatment. He utilizes PGTA in select cases and fitifies thought embryo transfer in artificial and natural endometrial preparation cycles. He has conducted research related to reproductive endocrinology and infertility, resulting in several publications. Finally, our last speaker in this speed round is Maike Schnoor, Dr. Maike Schnoor from Germany, who is replacing Dr. Susanne Elsner. Maike Schnoor works as a postdoc research associate at the Institute of Social Medicine and Epidemiology. She's an epidemiologist from the University of Lübeck, Germany. She has a University of Applied Sciences degree in health sciences and worked for several years as a nurse in different hospitals. Great career change. So Bart, I've introduced all this, so it's your turn to introduce Joyce.
Okay. You can hear me but not see me, if I'm correct. So this is Bart Fauser again, and I would like to start with the speech session and introduce the first speaker, Professor Joyce Harper. And the title of a paper, which was actually published in May last year with Lucy van der Wiel as first author. As chief editor of the journal, I have the privilege to pick every month an editor's favorite, and this was one that I choose because it's such a hot topic and we really need more data, and this was a paper providing additional data. So the title of the presentation and of the paper is The Prevalence, Promotion and Pricing of 3 IVF Add-ons in Infertility Clinic Websites. Please, Joyce, the floor is yours.
Thank you, Bart, and thank you, Jacques, and thanks RBM Online for inviting me to give this talk. So as we've said, it's the prevalence, promotion and pricing of 3 IVF add-ons on fertility clinic websites. And the work was carried out by my student Pantelista, and we asked Lucy and Jacques to come on board to help with the analysis and to help write up the paper. So going to the aims and background of the paper, we wanted to evaluate how IVF clinic websites were advertising 3 common IVF add-ons, and we chose assisted hatching, time-lapse imaging, and pre-implantation genetic testing for aneuploidy. Now, an add-on is defined as any technique that is a variation on or add-on to the normal IVF cycle. And there has been, as Bart said, a lot of controversy, but I think that definition is really quite straightforward. And it does also include complementary therapies, and we have an identical research method that we've done looking at UK IVF clinic websites and how they're advertising complementary therapies, including acupuncture and reflexology. So that's in press at the moment. So it's been a real privilege for me to be part of the Human Fertilization and Embryology Authority Science and Clinical Advisory Committee, which developed the traffic light system, which I'm sure you're all aware of. And the traffic light system uses green, amber and red lights to rate the add-ons, not every single add-on, but most of them. And we have looked at the evidence, mainly at randomized controlled trials, to decide which rating a add-on should be rated. Now you'll notice there's no green. A green would mean that there is conclusive evidence from randomized controlled trials that this technology improves live birth rate, increases live birth rate. So that's the only outcome. I appreciate there's many outcomes we could look at, but for simplicity, this traffic light system at the moment only looks at the effects on live birth. So in amber, we have, oh, not yet, sorry, in amber, we have the time lapse and the other add-ons we can see here. And amber rating is where there is some mixed evidence, and it's not conclusive evidence, but there might be some studies that have given an indication, but it's very conflicting. And then we have the red ratings, which includes assisted hatching. And this is where there's either not been studies done, or the studies that have been done have shown that there's no benefit on live birth rate. Now you'll see PGTA is red. It was amber when we started this study, but with the recent large randomized controlled trials that were published over the last few years, it was moved to a red rating. So the SCAT committee looks at all of the evidence on a regular basis, and we assess this information. So if we go to the results, thank you. So we can see here that we looked at a large number of websites in the UK, all the main websites. And if we look at the light blue bars on the first graph first, these are clinics that are not part of a larger group. So these are individual clinics. But what we'll see in the colored sections on the left is that there are a number of clinics, 37 clinics, that form as part of different groups. So group A, for example, has 8 different clinics in, and groups G, H and I just have 2 clinics within that group. So the first graph shows the number of add-ons that were advertised, either 1, 2 or 3. And what we can see that for groups, the clinics in group A and also in group E didn't advertise the same amount of add-ons between the clinics in those groups. So there was inconsistency. So for example, Clinic A has Group A has 2 clinics that advertise 1 add-on, 4 clinics that advertise 2, and 2 clinics that advertise 3. So you would have thought the philosophy of the group would be that they would advertise and offer the same add-ons, but for 2 of those groups, that wasn't the case. If we look at the second graph, this shows the number of clinics advertising each of the add-ons. And in the graph, we put the absolute number of clinics. But if we look at percentages, 28% of clinics advertise assisted hatching, 47% advertise PGTA, and 67% advertise time lapse. And also we looked at the claims that the clinics were saying these add-ons would do. This is very important for the patients. And there were various claims, which was very difficult for patients to navigate, such as this add-on would increase implantation or increase pregnancy or increase live birth rate or increase IVF success. And we also looked at the prices, and there was substantial variation in the prices. The mean price of assisted hatching was £450, for time lapse was £478, and PGTA showed the biggest variation, from the cheapest being £2,100 to the most expensive being over £3,000. So in conclusion, the IVF clinic websites provide key information for patients, and it's really important that this is accurate information. It was very common to claim that add-ons would improve live birth rates, and they can be hugely expensive, just for one add-on, even above £3,000. And there are many reports of many add-ons being added to a treatment cycle and doubling the cost. Now, the Human Fertilization and Embryology Authority has limitations on their powers. There's certain things they cannot do. So they have launched a joint venture with the Competition and Markets Authority into the IVF sector. And this includes many different parts, but also the use of IVF websites. So this report is coming out in spring 2021, and I'm sure that's going to really change the way that IVF clinics advertise. And the piece of work we're just about to submit for publication is we have interviewed some of the medical directors from UK IVF clinics to discuss these add-ons with them. Thank you very much.
Thank you so much, Joyce. I'm sure this will give rise to much discussion and questions from the audience. I have one question for you now. RBMO is a global journal. This is, of course, focusing on the UK situation. And my question would be about the generalizability of your findings. How relevant would this, from your perspective, be, these observations for other countries? Would it be the same, or will it vary tremendously?
Well, it does vary. So for the Netherlands, your use of add-ons is very different to how we do it in the UK. But Australia are another country that have done a lot of work about add-ons, and we have a lot of collaborations with VARTA, who are the equivalent to the HFEA, and they have found very similar problems to us. And so now there's a collaboration going on between, or various collaborations going on between VARTA and the HFEA and research groups around that, looking at how we can improve the information that we give to the patients. So yeah, different countries obviously have different amounts of use of add-ons, and in some countries it's more of an issue than others.
Okay, Joyce, thank you so much. We'll come back to this later. And I hand the mic over to Jacques.
Yeah, thank you, Joyce. So the next speaker is Professor Antonio La Marca from Italy, and he will talk, his presentation is about a paper that was published in RBM Online entitled Testicular Pain as an Unusual Presentation of COVID-19, a brief review of SARS-CoV-2 and the testes.
Thank you very much, Jacques, and let me thank Bart for the very kind invitation to this first RBMO broadcast. Well, it is well known that since the first global SARS outbreak linked to a coronavirus in 2003, so I'm talking about the first coronavirus, a possible testicular involvement was demonstrated. In men who died of SARS infection in China in 2003, the testicular analysis confirmed that orchitis was a complication of the systemic disease with germ cell destruction, few or no spermatozoa in the seminiferous tubules, leukocyte infiltration, and so on. SARS-CoV-2 is quite a different virus from the first one. 27 new mutations have been identified for the spike protein responsible for cell interaction and invasion. Spike protein interacts with the ACE2 receptor, which is nowadays considered to be the receptor for this virus. Then the transmembrane serine protease 2 and furin protein are then crucial for priming the S protein to increase the virus entry after binding to ACE2. Now, the testis should be highly sensitive to systemic SARS-CoV-2 infection owing to its high ACE2 levels. ACE2 receptors are also present in Leydig cells and in cells within the seminiferous tubules, including Sertoli cells and spermatogonia. In this article published on RBMO, we describe the case that we had in April, so very soon after the outbreak of the virus in the Western countries. In Italy, we had the very first case at the end of February. So in the mid of April, a 43-year-old man with type 1 diabetes presented with severe bilateral testicular pain started 3 days earlier. CT scan showed pictures suggestive with epididymitis. 12 hours later, he had the onset of dyspnea. He tested positive for SARS-CoV-2, so the diagnosis was pneumonia associated with epididymitis. On day 3, the patient was intubated and mechanically ventilated. On day 4, severe cardiogenic shock developed, so unfortunately the patient died 3 days later. We now have 3-4 cases similar to this one published in literature, indicating that testicular pain may indeed be an unusual clinical symptom for COVID-19. SARS-CoV-2 may indeed induce indirectly or more probably directly orchitis and epididymitis. Next slide, please. This is the Achua article. Is a very recent article, very interesting, and I think it's going to be highly cited. Testis tissue was collected from autopsies of 6 COVID-19 positive patients. Histological examination demonstrated inflammation with lymphocyte infiltration, but you can see the coronavirus itself indicated there by the blue arrows in the seminiferous tubules of a COVID-19 positive patient. Interestingly, in 3 out of the 6 studied patients, an abnormal spermatogenesis was recognized. Authors found a direct relationship between the degree of abnormality and the degree of expression of ACE2, hence again suggesting a relevant role for ACE2 expression in influencing the organ sensitivity, namely the testis sensitivity to the virus. And finally, very recently, 2 comprehensive meta-analyses have been published trying to answer whether the virus may be transmitted sexually through the semen. As you can see, both the 2 meta-analyses concluded that up to now the virus could be found in only 6 men out of 299 patients included in the largest meta-analysis, hence making this a very uncommon event. Interestingly, the 6 positive cases were all described in a recent study by Li and co-workers from China, which was very well published. It was published on the JAMA Network Open. However, this article has been criticized, largely criticized as soon as it was published, because authors included patients with acute and severe pneumonia. Sometimes some of them were comatose, in a comatose state, and so probably samples have not been taken in accordance with sterile conditions. So the possibility of false positive tests cannot be excluded, I think. In any case, overall results from the 2 meta-analyses indicate the absence of SARS-CoV-2 in semen among milder and asymptomatic men. Next slide, please. So coming to my conclusions, there is some risk of testicular injury during the COVID-19 disease course, which probably is related to the high viral load and significant viremia. The testicular injury may be direct due to the virus or indirect, fever, autoimmune response, cytokine storm, intramicrovessel coagulation, and so on. The possibility of viral spread through seminal fluid is an uncommon event that may be associated to very high viral loads. So in other words, the SARS-CoV-2 may affect the testis, but COVID-19 is not a sexually transmitted disease. Further studies are necessary to investigate the possible short and long-term effects of SARS-CoV-2 on male reproductive system and to ensure proper andrological follow-up for swab-positive male patients, even in the absence of pulmonary symptoms. Thank you very much.
Well, thank you very much, Antonio. That's super interesting. So is it possible that in non-symptomatic patients, they could have actually had symptoms, but since they don't come into the list that people check on websites and that they get from their doctors as a typical symptom from SARS, from SARS, is it possible that that there could be an effect more frequently than we actually realize? And if so, have you changed your practice? Do you now, when you see new patients, do you ask questions? Of course, you probably do that anyhow. Ask questions pertinent to, have you had fever, for instance, which is so typical for orchitis? Yeah.
Thank you for your question. Yes, exactly. What do you say are right? I mean, is right. I mean, these observations, this upcoming observation of a possible testicular effect of the SARS-CoV-2 in reality is changing my personal practice. I mean, as you said, every time we see patients sitting in front of us, we're asking them whether they were affected or not by COVID-19. And nowadays we have many research studies which I think are clinically interesting. I'm thinking to clinical studies in which we are investigating the fragmentation of DNA in sperm of COVID-19 patients, in patients who were positive, who tested positive for COVID-19. And we're trying to correlate this finding with the severity of symptoms. I think the story is not closely here. I mean, many things to learn in the near future. Yep.
Yeah. Well, I'm glad you're sticking with it, and thanks for that. And we're looking forward to hear more about this. Yep. And we'll come back to you at the Q&A at the end, of course.
Yep.
The next speaker is Dr. Mehmet Asoglu from Istanbul, and his lecture is entitled Preimplantation Genetic Testing for Aneuploidy in Severe Male Factor Infertility.
Thank you so much for inviting me to do this wonderful meeting. Our research question was, does the use of the preimplantation genetic testing for aneuploidy improve outcomes in the couples with severe male factor infertility? Next slide, please. Let's talk about let's talk about the study design. We conducted a single center retrospective study. We included a case with severe male factor infertility. Severe male factor infertility was defined as azoospermia or sperm count less than 1 million per milliliter. And then the couples had a normal karyotype, female age between 25 and 39 years. And then the patients underwent single embryo transfer with euploid or aneuploidy blastocyst. And then all women had normal uterine cavity. We created 2 study groups. The first group is the PGD group, women undergoing single euploid blastocyst transfer. The other group is non-PGDA group, women undergoing single aneuploid, aneuploidy blastocyst transfer. As you can see, also the exclusion criteria. Please, next slide. Before I mention about the the results, the main results of the study, I would like to tell you the patient characteristic a little bit. The age of the woman and man, and advanced advanced age rate in the woman were the higher in the PGDA group than the non-PGDA group, because this study, the group did not the PGD group did not receive PGTA because of severe male factor infertility. Their indication generally advanced female age or repeated IVF failure or recurrent pregnancy loss. When we look at the main, the outcomes, the both group were similar in terms of clinical pregnancy rates, miscarriage rates, live birth rate, implantation rate. And we ran the regression analysis, multivariate regression analysis, to determine variables associated with live birth. As you can see, only advanced female age, showed the statistical significance with odds ratio of 0.48, which means that the advanced female age was the most significant determinant or the independent factor that affect the live birth. Could you please go to the next slide? In conclusion, our findings were contrast to that of previous studies that found the increased incidence of the aneuploidy in cleavage stage embryos using FISH technique, but today's practice, as you all know, very, very different. We found that advanced female age was the only independent factor associated with live birth. And also we analyzed, the groups between male factor subgroups. We couldn't find any difference in euploid and aneuploid embryo rates in biopsied embryos between male factor the types. Based on the study, PGTA use does not appear to contribute independently to chance of live birth per transfer in couples with severe male factor infertility in the absence of advanced female age. This is important. Blastocysts, which after grading deemed transferable, have a good chance of giving rise to live birth in SMFM cases. We think randomized studies can provide solid evidence regarding whether transferring euploid embryos would improve outcome in those cases. Thank you so much for listening.
Well, thank you for your presentation, Mehmet. I think the incidence that was also reported by these early FISH studies now 20 years ago was very low in men with severe male factor infertility and chromosomal anomalies. So I don't think the suggestion was ever made that really would make much of a difference, but maybe I'm recalling it wrongly. But nevertheless, there probably is a role, don't you think, for pre-implantation genetic testing in men with extreme male factor infertility, in particular looking at paternal age, in terms of looking at spontaneous mutations. In the last 10 years, it seems to be that is a major factor in infertility, male infertility. Do you think that there will be a role in the future for PGT, not PGTA, but just looking at mutation analysis?
I think, yeah, that will be important in future. I mean, if there are specific mutations that can be found, that will be important in future to analyze for these mutations, to eliminate maybe some, the embryos, or to understand which patients, which group of SMFM cases should undergo the PGTA testing, maybe.
Okay. All right. Well, thank you very much. Stick around. We'll come back to you at the Q&A. Bart, it's your turn to introduce Maike.
Right, Jacques. So we move to the fourth lecture in this speech session. The presenter is Dr. Maike Schnoor on behalf of Suzanne Elsner. It's a paper published last year, and the title is A Comparison of Metabolic Health Parameters in ICSI-Conceived and Naturally Conceived Adolescents. Please, Dr. Schnoor.
Yes, thank you that I can present here our results. These are results from the third wave of the German ICSI cohort study. And in this wave, we determine the metabolic health parameters. And because, next slide, please. There are only few prospective studies which determine this topic, and the results are inconsistent. And furthermore, little attention has been paid on the health of the parents. So we asked the mothers and adolescents of the original cohort study, which started in 1999, and we asked them to complete a questionnaire with health-related questions. So mothers got an own questionnaire, which includes also questions about the health of the father, and mothers and the children were asked to attend a blood test, a single blood pressure measurement, and the adolescents were examined by a pediatrician or general practitioner. In addition, we selected a control group via 7 registry offices spread over Germany to compare them with the ICSI group. Next slide, please. Here you can see the main results of our findings. We first calculated the difference in means of the items of the physical development, blood pressure, and laboratory parameters. And then we conducted a linear regression model, first without including the parental items and covariates. And in the second step, we conducted a model including them. So we find the main reason or the main outcomes, results are, we found a statistically significant higher BMI score and waist circumference and waist to hip ratio in the male adolescents, and in the first model, and higher triglyceride level and GPT levels in the females. The adjustment for the parental covariates attenuated the differences in the males, except the waist circumference. It's still significant, and but it in the second, or including the covariates of the parents, did not do anything with the findings in the lipid parameters. We did not find any difference in the systolic blood pressure or diastolic blood pressure. So our conclusion is, next slide, please. That, okay, we found increased weight in males and lipid surrogates in females, and these findings were reflected in the parental data, what means that the parents in the ICSI groups had a higher weight and higher BMI, and the mothers had a higher level of triglycerides and GPT. So, but it's unclear whether the differences are clinically relevant for future health because they are small. It's unclear. But we would recommend to follow up this ICSI group to assess their adult cardiovascular health, and future studies should consider data from both parents because obviously there is a relationship. Yeah, thank you.
Thank you very much, Maike. I actually have quite a few questions, but we'll get to some of them later, and we'll see how the audience fits in.
Yeah.
My first question would be, because when you read the title, you know, what came to mind for me is the biological rationale. So ICSI-conceived children and metabolic health. Are there any biological reasons why, particularly in this group of offspring, you would expect metabolic abnormalities?
No, I think
let me rephrase. Previous studies have shown that there are subtle metabolic abnormalities in IVF children in general. There are high school children, there are several studies, subtle but significant. So this is already known from IVF children. And I was wondering, would you expect it to be any different from ICSI children? And it also relates to what is the ICSI indication?
Okay, now I understand.
In some countries, almost 100% of IVF is ICSI, and in other countries, it's much, much less. So it also has to do with the patient population. And if you would or only use this for severe male infertility, then I could imagine that, you know, there may be other health issues in the parents, in the father, which affects offspring.
Yeah.
Come back to the question. So
in our cohort, it is the main reason for using ICSI is the parental, the infertility of the father, and it's known that fathers have with infertility are more likely to have hypertension.
Okay.
So, and
then it makes a sense indeed. And then another question is about, because I was intrigued, the gender differences in male and female offspring.
Yeah.
So what could be the biological rationale for that? What could be the reason for that?
We have no really idea. Why is this different? Because the parents, mother and fathers, have a higher weight, higher BMI, but it's only reflected in the sons and not in the females. But we have no idea why it is. So it's important to see what happens.
Okay. Thank you, Dr. Schnoor. Stay tuned. And now I would like all the speakers to be present. And also, indeed, Jacques, the co-chair, we're all here. So now we start with, I think, the most challenging part, the interactive discussions based on questions by the audience. So, Jacques, you want to start?
Oh, sure. Joyce, Joyce, this will be easy. I know a lot of questions for you, okay? But I think you'll be able to deal with most of it, I think. From James Duffy, there's a question for Professor Harper. Thank you for the great presentation. What are your views about bundle payments, fixed price, based on achieving live births? Would they influence the use of IVF add-ons? Can I just add to that? It's kind of odd. 2 out of the 3 procedures that you chose are kind of, well, time-lapse. Why you use that incubator anyhow, because you have to have a culture system, and some of those incubators are really good, right? I'm not going into the companies, but they're really good. And assisted hatching, well, you have a laser around probably anyhow, and you have a microscope. So assisted hatching is so simple. If it's done right, it's really simple. Why even charge for those things extra?
Yeah, and that's the trouble, Jacques, that many units are charging for these procedures. That there were a few centers that didn't charge for time lapse, and I absolutely agree that time lapse is a wonderful incubator, and for any embryologist it's a no-brainer, I feel. But what concerns me are the claims that using this technology is going to improve live birth rate. And this is a discussion I've been having for more than a decade. For PGTA, it's been 25 years. And to be honest, it's driven me nuts. I said this year I wasn't going to do any more debates, etc. But I'm not doing any more on PGTA. It's got really too toxic. But people still want to wheel me out to talk about add-ons. So yes, we actually did this study a few years ago, looking at all of the add-ons, but we thought for this particular paper, we would just simplify it and look at 3 that are very commonly used. So yeah, if clinics want to use it and not charge, it's fine, but they shouldn't be claiming things that I don't think we have the evidence for. And we will all interpret evidence in different ways. But going back to James's question about the bundle, so I didn't mention, but in the paper we have mentioned that a number of the add-ons are sort of sucked in and hiding within packages that the clinics provide. So the cost of fertility treatment in the UK has just rocketed. And I have a personal reason to be really upset about this, because I had 7 years of fertility treatment and I would never have been able to have afforded the extortionate prices. So unfortunately in the UK and many countries, there's very little funding from the state to provide treatment. And what we're seeing in the UK and other countries is a huge commercialization. And I really wonder how much of this the doctors really have control over anymore, because there are big corporations owning these chains of clinics. And what do they want to do? They want to make money. So yeah, there's a lot of controversy going on in the UK. You may have heard a few weeks ago, one of the chains that I mentioned has a 3 cycles, no baby, your money back. So, you know, it's had a lot of discussion in the UK. Yeah. So we're in a really difficult situation with IVF in the UK, but not just the UK, other countries as well.
Of course. So what does the HFEA, because this is not just you, it's many people involved that to come to this system. What does the HFEA want us to do? Because if they apply this to the states too, which at least in discussions that comes up, and probably it is roughly applicable. What do they want us to do? If you remove all these methods, you think the results will stay the same?
So the trouble with the HFEA, and many people don't realize, they have very limited powers. They are civil servants and they are governed by the law that they can work within. So what I would love to see in the UK, I think the system that would work would be that if there's a new technology, that it goes into a holding area where we can do research, good quality research, find the data. If it's shown to improve any outcome, I just mentioned live birth, but there may be time to pregnancy, there may be miscarriage. I absolutely appreciate there's other outcomes that we could look at. And that's a big criticism of the traffic lights. And then, so if we have data that shows us that it is useful to patients, then we could move it to an approved treatment. But the HFEA, the way the law is set up is that we either don't approve a treatment or we approve a treatment. There's nothing in between. So there's nothing where we could say, but it's under a research license, it's not to be charged for, and we need the data before it moves into the green light, in effect. And now we're in a mess, because now we've got this huge list of add-ons. The ones we've looked at are just a minor part, and it's very hard to undo it.
Yeah, just curiosity here. Has there ever been an add-on that's green?
There is one that we're talking about. It shall remain nameless. But yeah, the trouble in our field, I'm sure Jacques and Bart are certainly aware, it's controversial, and people reading the same RCT will come up with a different interpretation.
Oh, absolutely. Yeah, you're quite right.
Yeah, it's the gold standard on that. We all read the same data, and so Darren Griffin called us stubborn, those that don't agree. But as I said, I've had 25 years of PGTA where I've seen the goalposts move, and here we are today with 2 talks, still looking at some of the fundamentals of whether this is really a viable procedure. This has been around since 1995.
Yeah.
And here we are. And Jack, I think you won those first papers with PGTA with Santi. Yeah. So, we're still working out some of the basics. But in the meantime, You know, I've tried to work out, we've got a few papers published on the USA data, which we can't tell if it's PGT for inherited disease or PGTA, but I would say the majority of PGTA. And, you know, this a couple of years ago, it was over 50,000 cycles in 1 year in the US, with 3 clinics doing PGT on every single patient that came through their door. And that was 2017 data. So the more recent data, I think we're going to see even more of a shift. So globally, probably 100,000 cycles done every year. And in my view, we are no further along than we were in 1995.
Yeah, so I think the frequency of PGTA usage in the United States is about 35%. It's a little bit of a guess because the national report that's of course publicly available through SART course only tells you how many PGT cycles a clinic does. That means PGTA is a little lower. Yeah. And so it doesn't distinguish between PGTA or PGTM or SR. It doesn't distinguish between all these different variations. So it's really unclear. And of course the data is there, but somebody needs to dig it out. Well, thank you for all that. There are questions for you too, Simone. Or if you have a comment about what Joyce was saying, I saw you nod, so I guess you're in agreement with her.
I'm totally in agreement with her.
Okay.
Totally in agreement with her, 100%, yeah. Oh, sorry.
Yeah. Okay, so question for you, Simone, from the audience here, from Mitch Sheila from the United States. Mitch is asking, can you please contrast the accuracy of blastocoele fluid versus spent culture media? To have a good and informative result, probably it's important to use the 2 techniques together. That's what he is suggesting.
I think that he would like to mean that is more informative blastocoele fluid or culture media. I think, as I told you before, yes, it is not the right matrix to understand which one is the best embryos. I think that with the PGTA, we can understand if we are working in the right way, if our incubator are good incubator, if our UTA, unit treatment, air treatment unit, the unit of the air, the quality of the air is good, the pH of the media is correct. So if everything is fine, you have more euploid embryos. Otherwise, less euploid embryos. Yes, then if you divide everything in the age, class of age, of course, the old one, more problem in the embryos. But the question is, I think that from that matrix, we have to looking for other, not euploidity. So, and moreover, the point is, why we are looking for euploidity in the culture media and in the blastocoele fluid. We know that euploidity is not the biomarker. So, and moreover, we have the technique that we are using, the biostatistic, bioinformatic device, strategies that we are using are developed for the cytogenetic, for the cells, not for liquids. As I told you before, it's like stay on the trees of fear looking for the apple. So it's something of unbelievable. Maybe we have to change really our biomarkers. And there's a lot of things that we can find over there. And we focus on that. We are really close to find other biomarkers.
Okay. Thank you, Simone. I think your voice is falling away now. Thank you very much. Bart, do you have any?
Yes, let's, before moving to other topics, I would like to have a brief discussion with Joyce, again, on the topic. You know, it's of interest to me as well, and we have written several editorials around this. And you were saying, rightly so, that the discussion may get pretty toxic. But therefore, rather than focus on the procedures, and you mentioned it briefly, wouldn't it be good to focus on the proper endpoints? And there are several papers on appropriate endpoints for RCTs around consort. What would be a live birth? Now you can even refine that. If we would agree that we have to go away from surrogate endpoints, certainly when informing patients, and go to real life endpoints like live birth, that would, I think, it would be possible to reach an agreement there, and that would make the whole add-on discussion much easier, isn't it?
I think it has improved, Bart. There, as you say, there have been a number of papers. Years ago, people were publishing RCTs that looked at things like even implantation rate and blastocyst rate and things. And I haven't seen any of those. Most of the papers, well, all the papers I've seen are really concentrating on either ongoing pregnancy, which is not ideal, but better than implantation, and live birth. But as you said, there's even discussions around live birth. You know, it should be healthy live birth, but then that gets complicated. So I really hope that the CMA guidance for the clinics is that they can't put things like implantation rate, increases implantation rate or decreases miscarriage rate on their websites, that they have to put live birth for any of the data. So I think you're right. The endpoint is so important, and I think we have improved that.
Let's move to Antonio's presentation. There are several questions. You presented the case report. If I understand you well, there have been other reports in the literature showing similar findings, and you've seen similar patients yourselves. So are there, how about effects on sperm quality? And how about effects on, should we test for that? Or is there any recovery after recovery of the disease? So if you put it in a broader perspective of sperm quality and screening of infertile couples, do you see that COVID has to play a role there in the near future?
Yeah, yes, thank you, Bart. Well, there are now upcoming reports. There are now many articles that are going to be published in our journals reporting on this story, on the effect of COVID-19 and SARS-CoV-2 on the testis and on the sperm quality. Well, it seems that there may be some impairment in the sperm quality, in sperm concentration, in sperm motility, in men affected by COVID-19, and this seems not to be related to clinical symptoms of orchitis. I mean, so the point here is that, as I said, SARS-CoV-2 may affect the testis, hence inducing orchitis, which has symptoms and which has a clinical pattern, a clinical presentation. But at the same time, COVID-19 itself, being a systemic disease, may affect organ function, may affect testicular function. We know that COVID-19 is characterized by a huge inflammatory state, characterized by the well-known cytokine storm. And this cytokine storm seems to affect germ cell function, leading cell function, Sertoli cell function, hence leading to abnormal spermatogenesis. I mean, fever itself, but also sometimes the immune system may affect testicular function. So it's a very complicated story here, where, as I said, SARS-CoV-2 may have direct but also indirect effect on testicular function. Regarding the proposal of testing the presence of the virus in the semen of affected men, well, as I said, COVID-19 is not a sexually transmitted disease. I mean, what it is now the most accepted opinion is that the virus can be in the testis only in rare cases. So it is an uncommon condition, which may occur when you have a very high viral load, when you have viremia. So in those cases, you may have the virus in the testis, but the testis is not the natural reservoir for the virus. What I want to say is that if a man is recovered from the COVID-19, you can be sure the COVID is not in the sperm.
Okay, that's a clear statement. Let me move to another presentation, the presentation from Dr. Schnoor. And this is about methodology, a question which also came up in my brain. So how do you select a proper control group for a study like this? Because we know, and it has been well established now, that potential abnormalities in offspring in IVF children may not only, or maybe not at all, relate to IVF, but it may relate to the parents who have more abnormalities. So how do you control properly for those confounders?
So yeah, we selected, how I said, the control group via the 7 registry offices, and the offsprings were matched to age and sex of the other ICSI group, the children of the ICSI group, but we didn't match the parents. So and we found that the parents in the ICSI group were in the mean 2 years older than in the control group. But we adjusted the first linear regression model for age, physical activity, premature birth of the children, birth weight, and highest qualification of the mother. And in the second step, for the we included the parameters of the parents, the weight and BMI, and if they have hypertonic or diabetes or something like this. And the for this blood pressure, we included in addition the blood pressure of the mother.
For you, your background is an epidemiologist. From an epidemiologist methodology point of view, do you believe that these control groups are matched sufficiently to control for the most significant potential confounders?
Yeah, I think so. We did a little, there were many items we included there, and they were similar. So, and where they are different, we found differences in the physical activity of the offsprings, or in the use of contraceptives in the females, and all of them, the items we include in the model. Okay. So
thank you very much. So let the discussion continue with Jacques, please.
Thank you, Bart. A question here for Mehmet. I think this is something that comes up over the years. You hear this back. Before thinking about doing PGT for male factor, extreme male factor, why not test the men themselves? There's a question asked here. Why not genetically test them first before you do that?
No, before, I mean, in our study, the all men has, you know, had normal karyotype. They were tested already, and then in our study, if man has an abnormal karyotype, we excluded them. Oh, right. And they had normal karyotype, and then they underwent PGT-A.
Okay, great.
I think maybe there is misunderstanding about the design of the study. We know if man has you know, the abnormal karyotype, like a Klinefelter syndrome, the possibility of having abnormal or aneuploid embryos increased. But the old man has had normal karyotype in our study.
In your study, yeah. Thanks for pointing it out again. A question for Joyce again. and it goes back to the HFEA again. I'm sorry to bring it up. Of course, you're not responsible for what they do, but you know, you're using that data that they bring up, and I understand they're not as influential as we all think. But the question here goes back to a paper of yours about 7-8 years ago, and I've referred to it also in some of my talks that you were sitting in the audience. I call it the Harper model. You know, the HFEA makes this common, you know, I wouldn't call it an error, but it's a policy decision to consider the evidence and prove evidence-based medicine. Now, not everybody agrees necessarily with that, but within some variation, we can argue, well, it's important. And you brought up, well, what do you need before a new method in embryology, before a new method is applied to the clinic routinely? And you had 7 points, and only one of those, it may have been 6, but there were quite a few points. And, you know, like, if you can, use basic animal research before you move on. And please let it be a postulation or hypothesis that makes sense, you know. So it was a sensible list. And only one of those, I think it was number 5, was evidence-based medicine. But now you're looking only at evidence-based medicine. So what happens to the other points, the other reasons to argue, well, this should be a new test that should be considered for clinical application? I mean, going back to PGTA, for instance, we all agree that there's a relationship between maternal age and the incidence of chromosomal anomalies in embryos. Nobody disagrees with that. I've never seen anybody disagree with it. Proponents and opponents to using PGTA routinely or not. So that's a logical step where you pass the first hurdle that you need to pass in order to go down that ladder, which you have put together in this paper that was published. I think it was Human Reproduction. I don't know, what was the year, 2012, 2013?
Yeah, about 10 years ago. Yeah, I mean, that was, as you said, the ideal scenario. And for some tests and technology, that model wouldn't necessarily apply. So, for example, you know, PGTA, eventually we did some work on mouse embryos, and others did.
Yeah.
But so there was different points that different technology would come into on that scale. So yeah, the HFEA, we are not just looking at RCTs. We are looking at any type of evidence. We are being broader. Some people say you're only looking at RCTs. We're not, but that is going to be, if there is an RCT, we're not going to ignore it. And so I just, listen, PGTA, I cannot tell you how much I wished PGTA worked. It has been the thorn in my career since 1995. There was one year I came off the stage giving the ESHRE chairs talk, and a couple of people almost murdered me for saying something about, you know, against PGTA, which was literally about 20 years ago. I just think that when you are having technology that is being done on hundreds of thousands of patients every year, and they're paying £2,000–3,000, dollars, whatever, that we should invest the money to do the RCTs. And we should, when we get the RCTs, we need to look at what it says. So when the STAR trial came out, I spoke to some of the authors and I said, so what are you going to do? And they said, nothing, we'll just continue. And their paper said it didn't work for women of advanced maternal age for an improved live birth rate. And we haven't even got to the frozen embryos and the cumulative live birth rate, which I think has a significant effect, as Carmen Rubio showed. So I think we're in a total mess, to be honest. We're not doing, there's very few things. It's, as I said earlier, it's such a money-making system now that if you were the clinic that turned around, and there were some on there that didn't advertise any of the add-ons we looked at. Yes. And, you know, So how do you look when you're marketing yourself to the patients? We can't undo this. The patients want these add-ons because they've read, being bombarded with all this information that it's going to improve their chance of live birth. And you can't undo that information. We can tell them all the science we want. The HFEA website's been there for years and it gets ignored. And so I think we're not doing the best for our fertility patients at all. And I think it's a real shame. And now people say, you said earlier, oh, assisted hatching doesn't cost much, so we should do it. Really?
No, I didn't say that. No, I didn't say that.
You said it's not very expensive. It's the laser's there. The laser's there, and we could just.
Why is there even a chart? I mean, it's like when you get 2 oocytes or 22 oocytes, you kind of charge the same, right? And so it never made sense to me that something that would be 10 or 15, 20 minutes of work, if most of it is paperwork, I guess, that you would make, what did you say, 450?
Yeah, no, exactly. I agree with you.
I mean, it's pretty ridiculous. So I understand why a genetic test costs a lot of money, because that is expensive. And so that debate is sort of separate from the other thing. But using a different type of incubator, that decision shouldn't come into play in terms of what it's going to cost to the patient.
But I'm sure you remember, and I really wish I kept it, the very first time time-lapse came in, and time-lapse was time-lapse at ESHRA, I think was around 2009, was the reason I wrote that paper 10 years ago about how we should be bringing new technology. I've told this story many times, but I said to the guy, they were telling people that they was going to improve live birth rate. And I said to them, what have you done? What experiments have you done to show this? And basically they hadn't done anything. No, they hadn't even grown normal human embryos in it. He told me he'd only grown tripronucleates and mononucleates in it. I was just horrified. I was with Daniel Bryson. It was, I lost it. And then wrote the paper. And I just don't think that's fair. And there were other examples. There was the metabolomics, there was molecular biometrics and other technology that patients paid thousands because it sounded great. And I don't think we should do that. We have these wonderful, shiny, high-tech clinics now, AI now coming in. Oh, AI can decide which embryo goes back. We'll charge you another 500.
There's a difference there, because now I hear a little bit of an attitude where already with future technologies, you have to be open-minded. The RCTs have to be done, the studies have to be done, but you have to stay open-minded that future technologies will make a difference. In the case of molecular biometrics, that company never came off, and no, I don't remember that anybody charged for that. I think that was all preclinical research. So I think we have to keep open mind that new technologies will have a possible effect. And so that's what we're all striving for. I mean, we have to, right? We can't just sit back and say, well, this is the result now, whatever it is, 30, 40%, and we're never going to do anything. Bart looks uncomfortable, so I'm going over to Bart. I'm going over.
Repeat the same arguments over and over again. This has been done 1,000 times already. So since the 19 minutes are over, I think, Jacques, if you agree, we should start with closing the session. If you agree.
Sure. It's my pleasure, and everybody. I think we've gone over time, and thank you, Bart, for pulling us back in. I like to thank everybody. So the speakers here, Dr. Maike Schnoor, Dr. Asoglu, Dr. Marca, and of course, Dr. Harper, as well as my co-moderator, Bart Fauser, for setting up, for being so generous with their time, presenting the lectures and being a co-host. Thank you very much. I also like to thank the International IVF Initiative, particularly the founders and the people who are on this core team doing this work every week, Peter Nash, Thomas Elliott, Shaista Sadruddin, Charles Palmer, Marianne Savedic. And then especially for this session, the new development editor of Reproductive Biomedicine, Duncan Nicholas, who really helped to prepare this. And then every week when we do this, there's the Q&A triage team. And today on the triage team, generously contributing their time were Kelly Catterson, Marianne Savedi, Sadruddin, Charles Palmer, and Peter Nash, and also Anna McLaughlin. This was another Charles Palmer production. Thank you, Charles, for your time. And with this, I'll hand it over to Bart, and I'll come back in a few minutes telling you what's going to be next week.
Yes, let me share, Jacques, with thanking all the presenters and thanking the I3 team, making this hopefully the first one of a new tradition, RBMO Live together with I3. Let me just have a few more words about RBMO. You heard earlier, this started by Bob Edwards in the year 2000, so we are in the 21st year now. What makes RBMO special is that it's really a global journal. When you look at contributions, it is really from all over the world, with certainly a dominance in the Asian Pacific region. What makes the journal special is that it goes all the way from really more society issues to basic science. I think that's quite unique. What is also unique is that it's still there as a journal, which is not backed up by one big society. It creates challenges, but also creates opportunities. And we've seen that last year with the COVID epidemic. Many journals were not able to publish many COVID papers because they were bound to guidelines by societies. And we have set up a rapid review system, and you will see later on, in human reproduction, in the first year after the breakout, the great majority of papers were published in RBMO because we were not bound to guidelines. We just looked, is it interesting? And we actually gave it a rapid review system. So I think the first papers were published actually in May. In next month issue, you will see we do that annually in a chief editor's report. So see where we are. And we have, when you talk about online, the history of the journal, it turned out that more and more, there was an extended period of time between submission and actually publication of the papers. We have reduced that to half in less than 2 years. That has been my main effort, chasing everybody, looking at the system. So now we can proudly say that between submission and the presence of the accepted paper is 17 weeks on average. So I think that's really, I'm really proud of that. And we see also, and that probably goes hand in hand with more submissions, more papers being published, rising in impact factor. So all this, I think that helps to raise the profile of the journal even further, hopefully like the RBMO Live event. And then last but not least, I would like also we have a system now that we highlight papers which can be read by everybody free of charge. So that's a system that we negotiated also. We discussed with Elsevier, our publisher. So we have hot topics every month, the editor's favorite every month, editorials almost every month, and review publications. They can be read globally without being charged for that. So you don't need a certain whatever via the university or personal subscription. Those papers can be read free of charge. And when you look, I just checked for this, when you look at the diversity of papers, for instance, the ones in press now, this goes from oocytes to mitochondrial DNA, to IUI, to PCOS, to progestins, to prevent an LH surge, to dropouts, about cumulative pregnancy rates, PGTA, of course, COVID and human sperm bank. So it really goes all over the place. And of course, there's certainly, I would invite everybody to submit, but particularly in the area of embryology, andrology, and experimental reproductive medicine. So we really like to continue the broad scope, and particularly in those areas, I would like to invite everybody to submit their work. And we can't give any guarantees. The only guarantee we can give is that we will look at the papers seriously. So with this, I would like to end. Thank you all very much and give the floor back to Jacques to come with the final closes.
Thank you, Bart. In my enthusiasm just before, I forgot to mention one name, and that's Simone Palini. I'm sorry, Dr. Palini, I didn't thank you at the end there. Thanks very much for doing all this. I know it was a lot of work. So same time next week, 3 p.m.